Based on a 2021 study, the mean age for female physicians to first give birth was 32 on average, in comparison to median age for non-physicians to give birth, which was 27. And I've read the JAMA Surgery article from 2021 about incidence of infertility and pregnancy complications in U.S. female surgeons. It was pretty bleak. 692 female surgeons were surveyed, and 42% of them had experienced pregnancy loss, which was more than twice the rate of the general population. Welcome to this week's episode of Promising Young Surgeon. This week, Dr. Valerie Libby joins us to discuss the issue of infertility in female surgeons, as well as her own journey with IVF and a pilot program that offers egg freezing to surgical residents at a majorly reduced cost. Dr. Valerie Libby is an OB-GYN in Atlanta at Shady Grove Fertility. She not only has her MD, but a master's in global public health as well. She went on to complete a residency and then a fellowship in reproductive endocrinology and fertility. She is an expert in the diagnosis and treatment of infertility and highly accomplished in the areas of fertility preservation and elective egg freezing. She is an avid traveler, tennis player, and enjoys biking and cooking. Importantly, and we'll dive into this majorly today, she started a program at Shady Grove Fertility for residents to receive discounted egg freezing. Thank you so much for joining me today, Dr. Libby.
Thank you for having me. I'm excited to be here and meet with you and talk about the program and my journey as well.
So, Dr. Libby, in your opinion, what is the data on fertility for female physicians and surgeons that you think is really important for people to know and be aware of and will affect their decision-making?
Yeah, I think that everything you just said is really important to know that, women are older when they have their first live birth, when they are a doctor in general, and surgeons in particular are even older. So of the doctors, surgeons are about 4.5 years older than other doctors when they have their first child. And so along with just age comes, comorbidities with pregnancy, but also difficulty getting pregnant. When you're older, it is much harder to get pregnant. The quality and the quantity of your eggs declines with age. So oftentimes you do find yourself in situations where you have to, seek help with a fertility specialist, often needing IVF, in vitro fertilization, and sometimes even needing donor eggs if you happen to have gone into earlier menopause. Or menopause and you're even older, you're older than 40. So being able to freeze your eggs is really important because it allows you to, not prevent the difficulty you may, or to try to prevent the difficulty you may have if you do seek treatment at an older age. You can use eggs from when you were younger, and the outcomes are much better than if you were to use your older eggs. So I do think that, it's really important to focus on, all physicians and all, in fact, all women in, professional careers that delay, want to delay childbearing or decide to delay childbearing or have to delay childbearing, and to just, bring a lot of awareness to the opportunity of egg freezing and the benefits that it may provide you.
Totally. And I love that. And I love how you talked about this is not a surgeon specific nor a female physician specific issue. I definitely would believe that it affects a lot of women in competitive professional careers. And honestly, in this day and age, there are more and more people who in their 20s don't find themselves in a position where they're seriously considering childbearing and things like that. And so I love that this is actually a much more universal topic than it even looks like at first. But I did want to ask you, I found it very interesting that female surgeons who operated 12 or more hours per week during their last trimester of pregnancy were at higher risk of pregnancy complications compared to those operating less than 12 hours a week. So that was wild to me. And does that affect the way that you counsel your patients? Do you have specific recommendations for female surgeons who are pregnant? And should they be changing operative schedules based on this?
I mean, I usually, as an OB-GYN, I did specialize in fertility. So I really only take care of patients until they're about 10 weeks pregnant. Then they go to their primary OB-GYN for the rest of pregnancy. Knowing that statistic, I think that's just important to know. If they are able to alter their schedule at all, decreasing their surgical hours, in the latter part of pregnancy may be beneficial. Anecdotally speaking, I have known, I would say more, people that are surgeons that have had poor outcomes in pregnancy than others, but I probably know more surgeons as well. So it's hard to say, but, if the study did show that, I would look at that study. I haven't seen that study, but, and validate that, maybe with more studies, but I would say, if stress definitely impacts pregnancy outcomes. And, when you are on your feet, for a long time during your pregnancy, even for an hour or two, your back starts hurting, you have a lot different weight distribution, and that kind of, burden that you may feel and the discomfort you may feel may actually impact the baby as well. So, it's just important to try to minimize stress and minimize, and to try to maximize relaxation techniques and stuff. So, I would say that the most you can do that in pregnancy, it will be more beneficial just because, surgeons do have this higher burden of infertility and do have a higher burden of comorbidities in pregnancy. So something to talk to your OB-GYN about for sure.
That totally makes sense. So it's tough, especially for resident physicians out there, who have less control over their schedule. But I hope that this is information that, people who have more control over their schedule can kind of take under consideration. And we can always put the link to this journal article definitely in the show notes. It's that JAMA publication from 2021, the incidence of infertility and pregnancy complications in U.S. female surgeons. So we'll definitely provide that citation for all of you listeners out there. So I'd love to hear about, can you just tell us about the Shady Grove Fertility egg freezing program for residents?
Yes, definitely. I realize that the burden of infertility is worse among doctors in general. And I really, being an OB-GYN considered surgeon, I, really wanted to advocate for women like us, in medicine, just, because we do delay childbearing. And I personally went through this myself. So I started this program about a year ago with the support of my company, Shady Grove Fertility and US Fertility. And we started this program called Egg Freezing for Surgical Residents. I wanted to, expand. I wanted it to be with all residents. That is my goal. But we had to start somewhere smaller because there are so many residents in this country that are female of reproductive age. So we tried to, we did the research and found out, you did as well, Dr. Harden, that there's a higher burden amongst surgical residents. So basically, normally in egg freezing, it has different costs at different clinics. Some clinics are better than others. Some are more expensive than others. Usually good clinics, will charge, between $8,000 to $10,000 to $15,000 for an egg freezing cycle. And often you don't have that as a resident or medical student or even a new physician. So it's, and you're in debt. And so, this is important to try to subsidize because this is the time where you really need to focus on freezing your eggs because you're younger than you'll ever be. So basically this program allows us to focus on the highest burden, population, which is the surgical residents. And in our cost at Shady Grove Fertility in general for one egg freezing cycle is $8,275. We do have really cool financial packages for people that are not residents for egg freezing that allow you to do it's called the Assure program. You can do Assure 20 or Assure 30, and you get to do for the Assure 20 up to 4 egg freezing cycles until you get to 20 eggs for $13,000, and you get money back if you get to 20 eggs in 4 cycles. And then for the Assure 30, you get to do up to 5 egg freezing cycles until you get to 30 mature eggs frozen for $19,000, and you get money back if you get to 30 eggs by your first or second cycle. So the Egg Freezing for Surgical Residents program is even more discounted than all of these programs. So it allows you to do 1 cycle of egg freezing if you provide evidence that you are a surgical resident or you've been accepted into a surgical residency. And it's $5,000. So it's a really good cost. Obviously, it's still expensive. I do realize that, but that is, the most competitive price I've seen out there anywhere for egg freezing. And, it's a good opportunity to get people in the door and comfortable with this process and, to allow them to at least freeze one round of eggs. And then, if they want to pursue more, we can talk about, our other packages that are also, when you look at the financial packages from other companies and other fertility groups, it's just a lot higher. And because we're the largest clinic in the country, Shady Grove Fertility, and we have clinics and all over the United States, in Florida, Georgia, Texas, Colorado, Philly, DC, Virginia, Maryland, New York, and California. Because we have clinics all over, and North Carolina, because we have clinics all over, we do have the ability to lower our prices because we have, so many more patients. So we just have awesome financial packages, and the ability to do this financial package is just so unique for, this subset of patients.
Yeah, that's incredible. I am shocked because I've definitely just from, reading the news and things like that, I've seen rates up to 15,000 for one cycle of freezing. I mean, how many mature eggs could someone hope for or on average get from one round?
It really, really depends on their age and some other blood tests that are basically telling us your ovarian reserve. So like your AMH, you're at day 3 FSH, and your antral follicle count, which is from an ultrasound. So if we know those things and we know your age, we can plug your numbers into an IVF predictor model that will tell us kind of how many eggs you may get from one round of IVF and how many mature eggs as well, or one round of egg freezing. But in general, I see people get anywhere from 0 to 3, in people that are poor responders or have low AMH levels, to up to 40 or 50. So it really depends on, a lot of factors. But on average, I would say, egg freezing patients get anywhere between, 7 and 15 eggs per cycle.
Oh, wonderful.
And you do want about 20 to 30 mature eggs for every child you want. So it might require you to do multiple rounds, but even having some eggs frozen takes a relief off. And, to be able to get through residency knowing you have some eggs frozen is just really nice.
Oh, absolutely. And, I'm a couple years out from residency training, but if this had existed when I had just matched into ENT residency or as a new resident, I absolutely would have done this. And I think that it would have helped a lot with peace of mind over the whole training experience in the past several years. And so that I'm so happy that it exists now. And I did want to ask, I know that you've mentioned, of course, your practice is enormous, tons of locations all around the country, but I know that only a portion of those locations are offering this program. So can you list again the locations where residents can go?
Yes. So Georgia, Tampa, Colorado, DC, Virginia, Maryland, Philadelphia, those are the current places that are offering this program. So if you live close to one of those clinics, then definitely, consider inquiring about this program. If you don't live close to these clinics, you can consider, flying and doing a cycle with us. It's just a lot harder in residency. So hopefully this program is really popular and we prove its benefits so that we can expand this program to all the rest of our clinics as well as to more residents in general. But for now, we have limited it to these clinics just to kind of see how it goes.
Yeah. And I think that even for medical students to hear about this would be really critical because I guess, once they have their match day documentation and they're moving forward, they kind of have like that spring of graduation, which is usually a fairly low key time. And that would be so wonderful to go into residency then July 1, knowing that even if you did have to fly and travel a little bit to your nearest location, that this is taken care of before the chaos starts.
Yeah, I agree. I love seeing patients that just got accepted into residency because I know this is such a good time for them to do it.
So when do you foresee, I guess, how long is this pilot program going? And then when do you think that it may expand to all female residents?
Yeah. So, I mean, I know that the next step of expansion will probably happen at the end of this year, 2024. I just don't know if the next step is expanding to all of our clinics or expanding to all female residents. We have to kind of figure out how we want to do that, and I have to get permission from my larger organization. But that should be coming.
Oh, awesome. Switching tacks a little bit, but on a very related note, for those who haven't heard about the recent Alabama Supreme Court ruling, in February it was decided that embryos held in a cryopreservation tank were legally equivalent to living children. This, of course, has serious implications and could affect access to reproductive health care. There was a subsequent ruling that did pass in Alabama about IVF protection laws, but I guess, of course, as a fertility subspecialist, I'd love to know your thoughts about the ruling and protections in place, the future of IVF.
Yeah. It's definitely a very scary time. And it's, very sad what, the legal proceedings that have transpired over the last several months. And, I do think that, our colleagues in Alabama, we don't have Shady Grove clinics in Alabama, but my friends that are, fertility doctors there, they are scared. But they also, are very hopeful and advocate, frequently. And like you said, there have been, things that have been able to protect IVF to an extent. In Georgia, we do see a lot of Alabama patients because of, everything that's been occurring. It's not too far away. I can say that, it's important to know that this exists, and this may, be coming, expanding to other states as well. It's important to go to a clinic. It's, my clinic is great because we have clinics all over the country, New York, Philly, like way up north, where if something were to happen in Atlanta, we can easily ship your eggs or embryos, right up north, and, and that's free. It's within our, clinic. So, and shipping eggs and embryos is easy and safe. And we do it all the time. And I've shipped my eggs all over the country, coming from different residency programs and stuff. So I think that's important just in case something were to happen. I'm very hopeful that it will not happen in my state, but I do know that, there's a possibility that it may. So I just think, talking to your provider about, what the current status is in your state and what they think, will occur if it does happen in their state, and what they plan to do with your eggs or embryos is going to be important.
And, as a non-expert, as an ENT, I'm so pleased to hear that it is really safe to ship your eggs. Like I have not known that. And I could see that causing anxiety for people, but that totally makes sense. And as you said, over your long medical career, like we all move usually a couple times. And so that's so fascinating.
Yes.
Could you share with us your own IVF journey during your medical career and now as a practitioner?
Yeah, definitely happy to. So, when I was in residency, I was 28 and in Dallas. And I was like dating, but, wasn't sure if I was going to end in, marriage and stuff like that. And I knew that I wanted to become a fertility specialist. So I'd have to do 3 more years after residency. And I was in my intern year, I believe. And luckily I had been exposed to egg freezing and IVF just because that's what I was interested in. But we didn't learn about that in medical school. So that was something I'm just thankful that I was exposed to at the time. I think now medical schools are talking about it more in training a little bit. So that's good. But basically I froze my eggs starting at 28, in residency. While I was an OB-GYN resident, I found that doing it while I was on night shift was much easier because I could just work my night shift and then right after night shift, just go in to the office for monitoring, because you do have to inject yourself every evening for 2 weeks. And during that 2-week period, you have to come into the office every other day for ultrasound and blood work to make sure you're responding appropriately and to titrate your medication. So being on night shift really, it was exhausting, but you just go straight to the office, get your ultrasound, go to sleep for the day, wake up and, inject yourself and go on, do your work. And then, I was able to have my egg retrieval. You're not supposed to operate or make any important decisions, for until the following day. So, that's something that you have to work with your residency director about. But yeah, so basically, I did that. I got about like 6 or 7 eggs the first time. You learn from every cycle. The doctors learn from every cycle, what you did well on, what you didn't do well on, how they can improve. So the second cycle, I got more eggs. I believe I got like 11 or 12 eggs. And then I did it. And that was like when I was like 30. And then when I was, and every couple of years, I found myself, okay, I'm still single, or I'm still not, in a serious relationship. And I, would go through the egg freezing cycles, and they really, every time it provided like such a relief for dating and for my career, to really focus on my career and not settle for the wrong person. Like, I knew so many people were doing it because it's easier to do, and so, because as you get older, you want your family to start and all those things. But knowing that I had eggs frozen really did take a lot of pressure off of me. And so I ultimately did this 5 times. I did it also in fellowship. I ended up getting about 35 mature eggs or so, 35 eggs, I believe, like maybe 28 mature eggs. And then at the age of 36, I met my husband. We were dating. We got engaged when I was 37, and I had an IUD in place. We thawed my eggs and shipped the eggs from, all over the country to where I was, Atlanta, and we thawed them. Now it's interesting. My older eggs from when I was 35 in fellowship that I had frozen actually did a lot better than my 28-year-old eggs. Now they were frozen at different facilities, one in Dallas, one in Cleveland. But I think the more important difference was that the technology has evolved so much over the last 10 to 15 years of egg freezing. It used to be something called slow freezing. And now we use rapid vitrification, rapid freezing, and that dehydrates the eggs, which eggs are actually the biggest cells in our body and even bigger than embryos. So when they're an embryo, it compacts. So to freeze an egg, and an egg is mostly composed of water. And so to freeze an egg, you do have ice crystals form. So they had to come up with a technology where the ice crystals wouldn't form, because ice crystals do tend to fracture the eggs and you can't use them. So they found this technology called rapid vitrification, where you dehydrate the eggs first. And then you freeze them, and then you rehydrate them to thaw them. And so using the older technology with the older eggs, that did not work as well as the newer technology. So I had a lot more eggs survive the thaw of my older eggs. So then we thawed the eggs. I think I ended up having, of like, let's say 28 mature eggs, I had something like, 15 eggs survive the thaw, which is not a great thaw rate. You usually 95% should survive the thaw at this point with this technology right now. So, but I think it was really related to older technology. So regardless, we had 15 eggs. We ended up creating 3 normal embryos, 3 euploid embryos of the 15 eggs, because they then have to fertilize normally. They then have to grow out to become a blastocyst or a day 5 embryo in the lab. That's the stage of the embryo development that you can actually biopsy and take a few cells off of. You don't have to biopsy the embryos to make sure they're normal. I did this on all of my eggs and embryos because I thought that it was important for me. It was important to know if it was normal or not, so I could start family planning. Do I need to do more rounds of IVF if I only have one embryo that's normal? Do I, and I also don't, I personally, and this is a discussion you'll have with your doctor and your partner, but what do you want to spend the time going through a miscarriage? Do you want, if your baby ends up being abnormal, if you get like your NIPS testing, the blood test that you get at 10 weeks to see if the baby is normal, when you're pregnant, like, do you want to go through that decision-making process? So for me, it was important to do the PGT testing, the pre-implantation genetic testing, to test the embryos. So tested the embryos, only got 3 normal embryos, and we decided to do another round of IVF and do fresh fertilization. So we did while we were, engaged. So we did another round of IVF. I got 6 embryos to biopsy, which is great with 1 round. And all 6 were abnormal. And I was 36. That was really sad. I was so sad. I thought, I was doomed. But then, I took out my IUD. I was like, let's just try on our own. And we didn't have success. We did 2 IUIs just because I wanted to speed up the process. And then, I ended up trying 1 more cycle right before the wedding or right after the wedding. And did so poorly that we canceled the cycle. because I was only going to get a few eggs, and I knew that I could do better, or thought I usually did. My AMH was dropping this whole time, as you get older, it drops at an even more rapid rate. So it was dropping. It was like 0.5 the last time I did my cycle, which was like last October. And so I just got married last October at 38, and that cycle was canceled. And we went on our honeymoon. I turned 39. We got pregnant spontaneously. I'm pregnant now. I'm 15 weeks pregnant. So I'm so happy. And we do have those other 3 embryos frozen. We obviously did a test to make sure that baby was normal. The non-invasive test that you'll do when you're 10 weeks pregnant, even if you did do PGT and did an embryo transfer of a normal embryo. But yeah, so I think egg freezing is great. It takes a huge relief off of you. You can focus on meeting the right person and not settle and focus on your career. But it is not a guarantee. And you may not ever use your eggs. You may not get any normal embryos. Just so many things can happen, and there's a huge drop off every step of the way. But it is nice because it does provide you the ability to kind of focus on yourself and your career. And so it was really helpful for me. I definitely don't regret doing it at all. And yeah. And I can answer more questions more specifically about my cycle if you have, or about egg freezing and stuff too.
Yeah, well, certainly, first off, congratulations, huge congrats, and
thank you.
Happy for you and your family. And that's all really helpful information, because I'm definitely more of a newbie to this world and this journey.
Yeah.
And so one question I have is it risky in any way to do the embryo biopsies?
So, I mean, there is a risk. It is less than 1%. So, there is a risk like tip damage to the embryo, and, losing the embryo. I've personally never seen that in my lab. I guess it depends on the lab and the embryologist there. But if you're at a good lab, the risk should be less than 1%. And so it is a conversation to have with your doctor. We generally have found that, doing PGTA testing, so looking for chromosome abnormality, is beneficial if you're 35 and older at the time of, egg freezing or doing IVF. If you're younger, because the rate of miscarriage is so much higher and the egg quality is so much worse after that age, that if you do, select the normal embryos, your time to pregnancy will be shorter. You'll have decreased chance of miscarriages. But I do think I would say, 80, 90% of my patients do PGTA, regardless of their age, just, to be able to plan their family better.
Yeah, that definitely makes sense. And I definitely believe it, but awesome to hear about the technological advances like over the past 15 years. Yeah, for people, for the next generation of docs like you who are going through that type of journey. Because I was shocked to hear when you said that the 35 cycle did so much better than 28.
Yeah, I know. It's crazy. I mean, technology is just advancing so rapidly in this field. And so, I mean, it's going to be even more advanced in 10 years. But yeah.
And OB-GYN, like as a field, I'm very aware that, of course, you guys are the experts at this. And so culturally, I think in OB, I would assume that during your training, there was a lot of like great knowledge base about this, support for it. But did you have to do anything special, or is there advice that you would give to a resident who does have to advocate for themselves? Like, especially if that person isn't in OB, because like other, some other specialties.
That's a good point. Yeah. I mean, I luckily I knew that even though I was in OB, it was early times of IVF and egg freezing. And, when I told people I was 28 and egg freezing, they were like, oh my God, that's crazy, but now it's like so much more common in your 20s to do this. But so I personally tried to, maybe I told my residency director, but I tried to make it so that it wouldn't really impact my colleagues, and that I would do night shift. And, the one day of my egg retrieval, I did work that evening, but I just didn't operate. So, technically you probably shouldn't, because you'll have high anesthesia, making important decisions. So just talk to your residency director about what they're comfortable with, and your colleagues like, hey, would you mind covering me or just, making sure that I'm making the right decisions, but it's minor anesthesia, at least in my clinic. It's just IV anesthesia. Anyway, so To advocate for yourself, though, I think it's important, to be transparent with your residency director as much as you can. You don't necessarily need to tell your colleagues or all the staff, but I think just asking them, advice like, hey, I'm planning on doing this. When do you think would be a good time? I'd like to do this as soon as possible. And if they're not supportive, then, that's a really unfortunate, because it doesn't sound like that's a really good program. But obviously it's hard. It's hard in surgical residency, especially if a man is your residency director to advocate for yourself. But so, night shifts are really helpful. And, if there is a female lead physician in in where you work that, you could talk to about this, that may be helpful too. And you can always reach out to me and I can try to give you some tips, but yeah.
That's awesome. It definitely makes sense. I'm thinking back because when I was a resident, I had a co-resident who was awesome, like very competent resident, very tough person. And she was doing a long head and neck case with like a really high up there attending, like a head, but like what you're referring to, it was an older male. And she actually had to take one step away from the surgery, actually, partway through. She like was feeling slightly ill. She knew she was pregnant, had not told a soul yet at work. It was very early on, but so she just kind of did have to take a beat, which would be unprecedented for her. And afterwards, he went up to her and he was like, well, what's up? Are you pregnant or something? Like, what's wrong with you? I saw that. And she was like, yeah, I actually was going to tell you for like planning purposes, but I am pregnant. Like, so, and he was like, it just is like a foot in the mouth type of thing. Cause he was kind of like jeering at her. Yeah. And that's the culture in a lot of, I think, like surgical training, especially if it's not very like cognizant of female fertility importance or issues surrounding that.
I agree. It's really unfortunate. In my training, we grew up thinking that, it doesn't matter if you're pregnant. It doesn't matter if you are, whatever you're going through personally, like we are all equal and we are all here together, and so you got to pull yourself up and like just be on an equal playing field. But now being pregnant and also, being a huge, advocate for women, it's totally different. And you do have to advocate for yourself and find women that are going to be supportive of you and of the pregnancy and stuff. And that may be rare in your field, but hopefully, the more we talk about this and the more everybody's doing it and these men's wives are doing it and men's daughters are doing it, the more, they're going to be more comfortable with it as well.
Yes, definitely looking forward to that paradigm shift, like continuing to happen. It's always evolving.
Yes, definitely.
So one question I love to ask everyone is, do you believe in karma? And why or why not?
That's interesting. I definitely do believe in karma. I think I do because I just always have. I feel like you try to put out, out there and it will eventually come back to you. And I don't know. I think I just always have felt that way growing up. I mean, I'm Jewish. I don't know if that has anything to do with it. There's some like Jewish mysticism and I'm not like into that mysticism stuff, but I think that I do believe in karma. I don't know how it's impacted my egg freezing process, I would say. I wasn't a great kid. Maybe it's biting me in the butt, but I'm also very thankful that I got pregnant. I got pregnant, and it so far so good. And I'm just so thankful for that. Helping women every single day, is a struggle when you yourself are going through it, infertility and have it, you have to put out all of the empathy and excitement for your patients, when they're pregnant and you want to, but it's hard. It's still difficult, to go through it when you're going through it yourself. So I do think that all the support I give other women is, finally, hopefully coming back to me.
I think it's an interesting idea. I do believe in karma, or the way that I describe it is that I do need to believe that karma is real. It doesn't happen on the timeline that we want it to happen on, maybe. But definitely. I was raised Catholic, so certainly just in terms of like there being like some kind of bigger picture.
Yeah,
can be helpful, especially if you deal with anything difficult, which I would put the entire process of becoming a surgeon over the course of a decade into that bucket of, just difficult things. You start to think, okay, well, what frameworks do I have in place? Like what are my true values and belief system? Just things like that.
Yeah,
So,
absolutely. Yeah.
But I appreciate you saying that because I didn't even think about until you brought it up, but that just must have been enormously difficult to see like your patients have these successful results when you were going through experiences of your own as a patient, but then you're also the physician, for so many other women like you talked about. But
it's really important for me to have that, have had that experience, because now I'm so sensitive to other women's experience of me being pregnant, and I wouldn't want to advertise to my patients this or anything, at some point it's going to become super obvious, and, just having experienced that myself, like it's really important,
Yeah. Will like make you an even better physician for it.
Absolutely. And having gone through egg freezing makes me a better physician. I mean, having injected myself every single night, learning how to mix the medicines is really, really hard, even as a doctor. Okay. Like, yes, we all did AP Chem. Yes, we all did like, biochem and all this stuff. But I don't mix medicines, and like, you have to like mix powder and liquid together and make sure that the dilution is accurate. And then you have to inject yourself, which we don't often do as physicians. So, and we're usually the biggest wimps anyways when it comes to needles. So it's just, it was such an important process for me to go through, so I could really have the ability to counsel my patients and, about really what the experience will be. And I've done it so many times, 6 times, and then a 7th failed cycle. So, I mean, I feel pretty comfortable with the process.
Yeah. And do you tell patients that, like, you're like, hey, yes. I identify with what you're saying. I can relate. I've done it.
I try not to make it like focus on me, but I definitely think that it's really, people do really appreciate when I say like, I totally know what you're going through, what you're going to go through. And I show them pictures of myself when I was injecting myself and my follicles and my eggs and what it looks like, my AMH levels dropping as I got older, just so it really hits home, and that we can be on the same playing field, and they know that. But yeah, I think it's really helpful. And I gear people towards my Instagram account because I do have like a lot of videos that have like, how to inject yourself, how to mix the medicines and all that stuff too. And people find that helpful.
Awesome. Thank you. And yes, we do. We're having your handle, all your information on ways to find you and your educational videos in the show notes as well.
Well, awesome. And I'll definitely send you the link for if someone's interested in the egg freezing for surgical residence program, how to inquire about that.
That's perfect. Is like a consultation free, or is that part of the whole package that they're paying for?
So all egg freezing consultations typically are free. The first one, because you do get some like blood work before, I believe. But I'm not sure if in the egg freezing for surgical residence program it's free. If it's not free, it's $300 if you're self-pay. A lot of people do have coverage for egg freezing for diagnostic testing. And so that will cover for any fertility treatment. So definitely, if you do have coverage for egg freezing, use that coverage. Don't use this program, because that wouldn't make sense. But if you don't have coverage at all, any coverage, then it's $300 for a consultation in general. And then you might have coverage for diagnostic testing, which includes the initial consult fee.
Oh, that makes sense. Well, perfect. Thank you. We'll include all that information below. I so appreciate you joining me today, Dr. Libby. It's been a real pleasure to chat with you and learn from you about this incredibly important topic.
Thank you so much for having me. I really appreciate it.
Next week, we will have Dr. Laura Votter on the podcast, an oncologist, to discuss medical error. Follow me on Instagram at francismay.md and at Rethinking Residency. Visit my website, rethinkingresidency.com, to learn more about resident physician stories and ways that residents can most effectively navigate the game of residency. I cannot wait to connect with you on the next episode of Promising Young Surgeon.